Hello, everybody. My name is Emma Cox. I'm Chief Executive at Endometriosis UK, and I'm absolutely delighted to be joined by some very special people that have been very generously supporting our work on surgery for endometriosis. And there's a very exciting video that's out, all of which you star on. And we'll be introducing people shortly. There is a queue and so that we already have an awful lot of questions that were sent in, and a big thank you to everyone who sent in questions. We will try and get through as many as we can. Those, if we can't, there are a lot of questions, we will do our best to try and provide information afterwards on our website and things like that as well. Or maybe even persuade people to do another webinar if we need to. So before we kick off with the questions, I'm going to ask all the panelists to introduce themselves. I think that's the easiest thing to do. So I'm going to just go around my screen. I don't know what order anyone else is in, but Manou, would you like to say hi?
Oh, hello, and good evening, everyone. Thank you for joining at this hour. And yeah, my introduction, my name is Manou Kaur. I work in Chelsea and Westminster Hospital in London, in the NHS Trust, and I am an endometriosis specialist. I have been a consultant since the last 3 years. Prior to this, I worked at Liverpool Women's Hospital, and I am quite involved in teaching of our younger generation, also surgeons who want to get their skills further embellished to help them further. So I am a proctor for intuitive surgical. That is my only disclosure that I need to make. So looking forward to speak to all the colleagues as panelists, and hope to answer many of your questions that you have had.
Brilliant, thank you, Manou. And Claudia.
Hi, yes, so I'm Claudia, endometriosis nurse specialist at Guy's and St Thomas's in London. I've been in the post since 2014, and I do a lot of work with endometriosis nurses nationally, so it's a great privilege to be involved in such an important bit of work, and I'm delighted to be here to be able to support Endometriosis UK and answer any questions as best I can. So thank you for having me.
Thank you, Claudia. Claudia is also most local to our hospital. Your hospital is most local to our office, so we do go and bother Claudia sometimes. So thank you, Claudia, for putting us up with us. Elaine, please introduce yourself.
Hi everybody. Yeah, my name is Elaine, and I'm the leader of the support leader for Endometriosis UK Cumbria. Started the group in 2019, and they're actually meeting tonight without me. They're going to the pub tonight because I'm here with you, but that's good on them. So just a tiny bit about my endometriosis journey, really. But before I had my surgery in 2022 of May, so just over a year and a half, I had stage 4 endometriosis, so deep infiltrating. I had adhesion, so I had a frozen pelvis and kissing ovaries. I also had to have a bowel resection, and yeah, they took the cervix out, everything, the ovaries, the womb. So that's where I'm at, and so I had to navigate from endometriosis to menopause, from one day to the next. But thankfully, it's all going well.
That's great, Elaine, thank you for that. And thank you for missing your pub trip with your group. So thank you for that one. And Lexi, please introduce yourself.
Hello, yes, so I'm Lexi Clayton. I am the support group leader for Staffordshire, and I started that in 2017. So I've been working with the group for quite a while now. Again, in regards to my endo journey, I was very first diagnosed in 2013. So it's just been a little over 10 years since I got my first diagnosis. I've had about 6 surgeries so far. It's all got slightly progressively worse over time. I've just had an operation in July where they had to remove one of my ovaries and fallopian tubes. So I've had a bit of a up and down journey with endo, but it's been great to be able to support people through that too.
Thank you, Lexi. And we have someone behind the scenes, which I'm just going to say hello to Ushma, who's done all the work for this. So Ushma, thank you very much for being there and doing all the work for this. So what we're going to do is we're going to go through questions. And what I've said to the panelists, I'm going to start by asking someone, but other people will drop in and say what they want to as well. And we're actually going to start off around surgery, given the title of this. So one of the questions I thought was very pertinent actually was, when is the right time to have surgery? And who decides? Do I decide as a patient, or does my doctor decide, or how does it work? So Manou, I thought we could start with you and then see what Elaine and Lexi would like to add as well, and Claudia might do too.
Well, in terms of doing surgery, of course, in an ideal world, you would say when you have the suspicion or you have the diagnosis, you want to have surgery as soon as possible. But there are a couple of things that we need to keep in mind when we plan surgery. So first of all, the diagnostic workup, what we find very crucial, needs to be complete, because that really allows us to have the right resources available, the right people available to make it a safe and as complete procedure as possible. So definitely ensuring that you have been able to talk about your concerns, your symptoms with your consultant, and they have gone through what potentially need to be additionally investigated apart from the the routine checks you might need as a scan and things like that. And also, I think what we often forget as clinicians, and it is very important, is when you as a patient are ready to have surgery, because sometimes it's the anxiety, sometimes it's the environment around us which is pushing us to have surgery as soon as possible. But if you're mentally not prepared, or we don't have that physical capacity to undergo intermediate or major type of surgery, then sometimes it's best to wait a little bit to optimize your health. So I think those are the things that I always find important, because it's not just about, we need to have surgery and having a laparoscopy scheduled on the list. That's not it. You need to have the right team involved. Sometimes you need a joint surgery, so you want to make sure that you get your surgery on a day that colorectal surgical support is available, just to give an example. Unfortunately, at the moment, we are very much struggling with the long waiting lists in the NHS, and hopefully, we see a light at the end of the tunnel, and we can work through the backlog by opening up initiatives such as, Guy's and St. Thomas has done recently with high intensity theatre lists. We have done it in Chelsea and Westminster Hospital, and I see at various other places in the country that happening as well. Of course, with making sure that you do a case selection. That's what I think.
Thank you.
I'm sure Claudia will add into it from her experience.
Yeah, so just exactly as you say, I think it's a conversation. It's a conversation that isn't, if the decision is, well, surgery isn't perhaps right for now, it doesn't mean it's not right ever. It doesn't mean if you're saying you're not going to have surgery right at this point, you're going to try something else. It doesn't mean that it's a no. Endometriosis is chronic recurrent disease. Your whole treatment and care should be a continuing journey and a revisiting of your priorities and your condition along the way, and it should be a conversation.
And one thing I forgot to mention is also when sometimes the timing could not be right because of things which are happening alongside. You might be going through a fertility treatment, and therefore it's not the right time to have a complete surgery, where we would not want to be too invasive to the ovaries, for instance. And like Claudia mentions, it's not that if it's not the right time now, it will never be the right time. So.
That's great. Elaine, let's come to you next. How did you decide when your surgery was right for you?
Well, many things that sort of Manou and Claudia said resonated with me. So I was diagnosed with endometriosis when I was 33 years old. and I had my surgery when I was 46 years old. And all of that is because I was not ready. So 100% agree that, you know, you will know. When I had my surgery, I was ready, but there were certain things that led up to me being ready. And when Manou was talking about being mentally prepared, I think I'm really lucky in that for the work that I do as a coach, to do, you know, resilience, emotional intelligence, intelligence, that really helped me during those 13 years to build that up. And also I optimized my health by doing a lot of what was running basically, and I've actually literally just got back into it. So before I did my surgery, had my surgery, there was about a year where I had a personal trainer and I was getting my body strong as well. But the sort of critical turning point was when I had a conversation, like Claudia was saying, I had a conversation with somebody who, for the first time, explained everything, you know, that was going on. Everything became clear. An endometriosis specialist who was a surgeon, and from that day, I was confident. I never had confidence before that to make the step, but from that conversation, it was the right time for me. And so yeah, 13 years after my diagnosis, I was ready for it.
Thank you. Now, Lexi, you've had more than one surgery, haven't you? So what's your process be?
So I think for me, a lot of the time when it came to having surgery for me, it felt almost like a little bit like a foregone conclusion, because I usually held off until I wasn't coping very well with my pain and my symptoms. And so and sometimes that was sooner, where I had maybe only a year or two between surgeries, and sometimes it's been a lot longer. And I think for me, it's been more recently about making sure that I'm in a good position with what I'm doing outside of my health. So I'm a student nurse. So my last surgery had to be really carefully planned around when it wasn't going to impact placement, where I've got to do quite a lot of hours. If anyone's a nurse out there who has done this, or currently student nurse, or any healthcare training professional, we have to do about 2,300 hours, I think it is. And so for me, it was optimizing the time when I would be able to recover the best without losing any hours and losing any of my course. And it's been the same at other points, making sure I've had surgery, preparing myself for the next step in what I'm doing in my life, be that career, be that health, be that moving in with my partner. It's all been that kind of making sure that it's the right time for me, and having that conversation again, as Manou said and Claudia said, with my consultant, that I'm making the right sort of decision for me and not rushing into something that I might not benefit from.
No, thank you. That's really helpful. And you've touched on, and we'll go straight into the next question. One of the questions is that will endometriosis always come back after surgery? Now, I think that certainly from my experience, we speak to people, some people have one surgery, and some people have none, but some people have one surgery and that does a really good job. Other people, it might come back. Now, I'm going to start with Manou. Could you just explain, do we know if it will come back or not? Is there any way of telling?
Well, you can't be certain 100% because, like you just mentioned, individually it can vary from one person to another. And perhaps we don't know much about the different types of endometriosis. We are just seeing the lesions as they're appearing at the moment. And maybe there is like different genotype associated with it from genetic perspective or the molecular aspect. But we don't have that information. At the current moment, what we know is just from observational studies, because you can't do a randomized control trial and say, okay, we operate on patients and then we do a repeat surgery as a screening tool. So that's just not justified ethically. So from observational studies, what we know that especially the severe types of endometriosis, looking at stage 3, stage 4, if a good amount, like complete surgery has been carried out according to the right principles by an endometriosis specialist, at 5-year follow-up time, you would, excuse me, have around, excuse me, you will have around 20%. So the figures are between 9 to 30%, but on average, around 20% of those women will have some form of recurrence, which will require, further intervention. So that means that we have to also acknowledge that 70 to 80% of women will have a good definitive control of the symptoms if it's carried out very correctly. So it's a bit difficult to say, but we do see that some patients recur much quicker. We don't know the answer why, but as clinicians and as surgeons, our duty is to make sure that we be as thorough as possible. And nowadays, with the new technologies coming on board, like, better scopes and better, platforms to do surgery, we can see more, and therefore, hopefully we treat more, and the future will tell whether that's making a big impact.
No, thank you. And I think, one of the challenges we all have is that we don't know what causes endometriosis and why it grows in the first place. So we don't know the answer, but the answer to that is it might do. And Elaine, you want to say something?
Yeah, I just wanted to say, because my endometriosis nurse, so after the operation, she said that I knew that I would have to go on HRT. But she said that I would need to take progesterone as well as the estrogen to prevent the endometriosis coming back. And I've had to tell that to different, like a nurse, even the doctor that I saw today, wasn't really aware of that. So would you say that is a sort of preventative measure for endometriosis coming back after surgery if you've had a hysterectomy?
Well, I'm very glad you mentioned it. I'm sorry to, drop in again. It is something that we have to always make sure to mention it to the patients, because again, from lots of observational studies, when we collect the data, and it just shows that if you use what we call adjuvant hormonal treatment, so any type of progesterone containing method would be helpful. And there are a bit more newer types of progesterones on the market which are helping a little bit more, so they do help to minimize that risk. Of course, it's not completely robust to say if you take it you're not going to get a recurrence, but on the basis of the understanding of how endometriosis often tends to grow, it has the tendency to grow more if we are in a very estrogen rich environment. And if you have had surgery, let's say for endometriosis, and you might have had your ovaries removed and the womb removed, everything, and you might say, well, I don't need anything else. Sometimes I still choose my patients to give them not just the estrogen, which is given transdermally and therefore has less side effects, but also a little bit of progesterone alongside, just because we don't know what that little amount of estrogen in some patients can do. It really depends upon the severity that you come across as well.
No, that's great. Thank you. And I think, for those people who do go through a hysterectomy, making sure that you speak to your specialist about what else happens would be great. Now, Claudia, I'm going to come to you because I'm absolutely sure that you all have had this question asked to you, which is, I'm scared, what happens if surgery doesn't work?
I know, it is really scary. It's really daunting in so many ways when you go for surgery, because if it's your first surgery and you sort of don't even know if you're going to have endometriosis found during the surgery, that the anticipation of that, wanting a diagnosis and validation of your experience, but at the same time terrified of what that diagnosis actually means for you in the longer term. I think, if you've made the decision to have surgery, it will have hopefully been, following a good discussion about, the aims and objectives of that surgery and your symptoms around it. And hopefully you're going to be in good hands. You're going to feel, empowered as you're going in and understanding, what's going to be happening during that surgery. And then when you come out of the surgery, it's, does it work? Doesn't it work? There's, so many different factors in the experience of someone with endometriosis. So, we know that, the inflammatory active endometriosis itself is sort of one element of your pain experience, but there are so many other different elements involved in it. So quite often, it won't be as simple as, you have surgery and that's everything is resolved. And often it will be a matter of, adding in some, physiotherapy or, dietary tips and things like this, different things to help, manage your overall experience. But, I suppose that would be my answer is, going in armed with the best information you can get. And hopefully, having contact and having follow-up afterwards to, review you and see how you're doing after the surgery. And, this is what I always say to my patients, we're looking at unpicking your, physical experience and your psychological experience of it all, and looking at the different elements and seeing, okay, well, surgery has massively improved, hopefully, this one aspect of your experience, but you're still left with this and this. Let's see what we can do to help with that different element. But again, it'll be a conversation. And
That's great.
I know it is daunting. It is scary.
Okay, so do make sure you speak to people if you're concerned about it. And Lexi, one of the ones I'm going to ask you, and Claudia and Manou might want to jump in as well after, is someone's asking when is it worthwhile to have surgery? So if someone has pain for a couple of days a month, do they say yes to surgery, or how do they balance up the risk? And I know you talked about earlier about having to decide when to have surgery. What were your sort of thought process? And bearing in mind it will be different from everyone, but just Lexi's experience I think would be helpful.
Yeah, I think for me it was about quality of life. So my decision was always kind of hinging around when my symptoms for me were no longer manageable, or when they were really impacting my quality of life. So it might have been that the really intense pain, for example, was only for, I don't know, maybe a week, a month. But some of the other symptoms I experienced, like pain with sex, pain with bowel movements, things like that, that were affecting me far more frequently, actually had a really negative impact on the wider scope of my life. And that was when I start to make that decision about this now might be the right time for me to have the surgery to help with my symptoms again, because clearly there's something happening, at which point refer back to my specialist and we have that discussion. So I think it's important to weigh up your quality of life. If you feel like you're managing well, if you're coping quite well, then it might be that you don't feel that the risks are outweighed by the benefits. But if it really is impacting your quality of life and your mental health, it doesn't always have to be about the physical pain manifestation. It can be about the whole experience holistically as a whole picture. And that can be a big factor in making that decision regarding surgery.
No, that's great. Thank you for that. Lovely answer in that one. Although I'm sorry you've had to go through that, obviously. And so one of the things, we've had a couple of questions that I'm going to sort of try and join together. So they're linked around excision surgery. And we've had a couple of things about who's qualified to do excision surgery or who's trained. Do you need to have excision surgery? Have you had to have ablation first? And I think it's probably worth just clarifying, Manou. Do you want to just summarise what excision surgery is, or what ablation surgery is?
Sure. I think these are very valid questions, and they, it just shows also that the patients are seeking that information and they are looking up, and I think that is really incredible to give that empowerment to the patients. It is important to know what types of surgeries we can do, and the two mainstay of those kind of surgeries are around ablation or excision. Excision means you excise, and excising means that you actually really take out whatever the lesion or disease you want to call it, by making cuts into the area where the endometriosis starts to grow, and then you basically just remove the tissue until its deeper layer is found to be affecting that particular structure or organ. Good thing about excision is that it will tell you about the depth of the lesion, and therefore a lot of studies have shown that it's more beneficial, or to a certain degree, especially for deeply infiltrating endometriosis, because you want to go to the root of where the endometriosis starts to grow. Of course, that requires that you need a surgeon who is skillful or able to perform that kind of surgery, because sometimes endometriosis can start to grow deeper into the tissue layers, which might be very close to some crucial structures. And if we are not careful enough, we can damage those. And you don't want to compromise any other organ or other functioning in your body, because you want to get rid of endometriosis by specific type of surgery. So it really is important to have a chat with your surgeon when you are going to have surgery, to ask them what way will you perform the surgery.
Mm-hmm.
However, on the other side, there will be some instances where ablation might be the right thing for you. That are, I mean, those are specifically scenarios where we would be looking at very superficial lesions, and you might be in a region or in an area where you don't have the expertise around surgeons who are able to do the excision, and it would then be a bit sad if you are not going to have surgery at all. Or instances where you might have, like, you know, what Claudia was mentioning about inflammatory endometriosis sitting on the surface of the uterus. What do you do with that? We can't start cutting into the womb lining at the surface, because that will damage the womb too much. And then you still want to get rid of that kind of endometriosis. And the best way to deal with that type of superficial endometriosis, which is not growing into the tissue, but is actually just as a layer lying on top of a structure such as the uterus, then that is absolutely fine to ablate that type of area.
No.
I personally use a lot of excision. I don't do ablation apart from this kind of lesions on the surface of the uterus. Sometimes you can excise to a certain degree even inside the uterus, but then you have to have deeply infiltrating endometriosis and not surface endometriosis. Wouldn't make any sense to start cutting out womb muscle for just very superficial lesions. Ablation is effective in superficial lesions. There are a couple of studies, even from the UK itself, which have shown its efficacy, especially for the early stages. And it has also shown that with ablation, if endometriosis is associated with subfertility, it can improve that, for instance. I hope that answers a little bit of
Yeah,
Emma.
I do. Yeah, so I mean, I think one of the things is it's not straightforward, is it? Because excision can be the right thing, but on occasion, ablation, if you're not going to remove a bit that you don't want removed, I saw, you know, on that one. But also we hear people talking about burning, and it's worth noting that some people do excision using laser tools.
Yes, exactly.
So you can have laser surgery that is excision. So it's worth bearing in mind. So I do know that some people say, you know, you don't want to use, you don't want burning, but actually if you're using very precise lasers, they can be used as cutting tools to remove endometriosis. And I think that
you can imagine if there is like very just a spot of endometriosis. I know that lots of people in the past have also, you know, just ablated it. That means they destroyed the superficial lesion, and there is not necessarily anything specifically majorly wrong with that. But if you have larger lesions and you want to really send it to the lab to get histological diagnosis, absolutely excision would be the best way forward.
That's great. Now, I believe, Manou, all BSG registered surgeons have had training in excision. Is that correct?
I would hope so that it's
Yeah.
but it is, but we do know that it would be the case because we have to submit every year a video of our surgical cases, which kind of tells the society that, you know, this surgical specialty or the subspecialty within endometriosis in the trust is able to perform excision surgery. So in essence, everyone who is listed as an BSc accredited surgeon should be able to perform excision.
That's great, because we do get asked by that, and there'll be many people who've done the Royal College of Obstetricians and Gynaecologists courses and the BSG courses, and will have those skills as well. So if people are interested in that, that's where to check those out. Now, should we move on a little bit to recovery? Because I know people do ask about that. And Claudia, I'm going to start with you. And I do realise this is how long is a piece of string. We're going to ask you about recovery. Now, just to tell a personal story, I had an ovarian cyst removed, like, we're talking 30 years ago. And at the time, I was a lot younger. And I just thought, well, having 3 cuts in my tummy, how much can that hurt? I'll be fine in a day's time after my surgery, which wasn't quite true. So it depends what they do, doesn't it, inside, Claudia? But what's recovery? How long on average does recovery take?
Yeah, you're absolutely right. It's very hard to say because everyone's really different. But what I always say to women is, you know, and it really does differ depending on how much is done. Because, you know, laparoscopic and robotic surgery, as you said, doesn't look like much from the outside, and it can be quite different if someone's just had, you know, very basic sort of diagnostic laparoscopy where nothing is done, to the really sort of extensive excision and bowel surgery and all sorts of things that can be done laparoscopically and robotically. So I always say to people, just you know, take it easy, listen to your body, take as long as you need, you know, take longer rather than less, particularly with work and things like that. Be kind to yourself. If you're looking for a time scale, we say, and Manou will probably give a view on this as well, but, you know, a couple of weeks, you're normally going to be feeling a bit better. If you've had fairly extensive surgery, if if you're getting joint surgery with colorectals and things like that, then I tend to say to women, you know, 8 to 12 weeks, you know, to have time off to really recover. You know, and often these women have had, you know, a terrible experience on the run up to surgery, you know, and are coming out of, you know, what can be really quite a you know, traumatic experience that they have to recover from overall in the journey on the run up to it. So there's lots of things to take into account.
Yeah. I think so. I think the main thing is laparoscopic surgery might look the same on the outside, but is very different inside. So it's a personal thing. So if you've got people going, oh, I only took 2 days, you know, a week to recover, and someone else saying I took 3 months, they probably had very different surgery done. I don't know if Lexi or Elaine, you've got any comments on the recoveries you experienced.
Yeah, I mean, as you're saying that, I realised that I know somebody who's had surgery, she had a hysterectomy, you know, because she had the endo a few weeks ago, and her recovery seemed to be a lot quicker than mine. And now I think I'm realising it's because I did have extensive excision, you know, surgery, and I had an MDT, and I had a bowel resection, and I think that, for me, what I'm seeing is that when you have a bowel resection, it takes a lot longer to recover than if you know, if you don't. So my recovery, I think it was probably more towards the 12 weeks before I really started to feel like I could do things. Even at the beginning, I was told, you know, you've had a hysterectomy, so it'll take about 6 weeks. You know, don't pick up a kettle for 6 weeks. Don't, you know, do anything. Don't drive for 6 weeks. And I did respect that, but still after the 6 weeks, it was tough. So I did have to listen to my body. Sometimes I pushed it, but you're right. Your body will tell you when you need to stop and not push it.
Yeah, and to add to that, out of the operations I've had, I've not had any 2 recoveries that have been the same. Every single one has been different. And even sometimes some of the surgeries that had been a little bit more extensive, one of them, I climbed Vesuvius 3 weeks after my surgery. The others, I've had maybe less extensive excision, but then I've had a really tough recovery that's taken me much longer than I thought. So every single recovery, even in the same person, can be totally different, and it just depends on your body, how you are at the time, how well you feel generally. There is just so much scope for difference in experience from one person to the next and from one surgery to the next.
Yeah. No, great. And so do listen to your bodies. And linked to that is one of the questions is how is, and again, Claudia, I don't know if you've got a medical answer for this one. How long is it recommended to wait before exercise after surgery, and how will I know when I'm ready?
Oh, goodness. Again,
Is there an answer?
There isn't really. I mean, obviously the laparoscopic and robotic surgery, it's quicker than if you have an open surgery, but again, it's very much listening to your body, starting off gently, not leaping straight into, I mean, climbing Mount Vesuvius, goodness. but and I mean, another thing is people will often find, they'll be feeling a bit better after a couple of weeks, do a little bit more, and then feel as though they're having a setback, and they'll be worried that something, isn't working well. But again, that's just the way it goes. You move a little bit forward, see how you get on, do it gently, bit by bit. Yeah, don't be hard on yourself and listen to your body. Sorry, lots of vague answers because there's not really any definites, I'm afraid.
It's very endometriosis, isn't it? There's different answers because it depends on where it's growing and what's done, and that's one of the things we have with endometriosis. It's not enough there's not enough consistency to give everyone the same answer. Now, one of these things, now Manou, we get asked this a lot. I'm absolutely sure all of you will as well, which is around, is there, I'm having surgery, is there any way to monitor or prevent the endometriosis recurring? And I know that, some people sometimes have coils fitted, or there's hormones as well. But would you and I know this is also probably like a massive exam question you could spend hours on, but could you, are there any ways to try and safeguard against endometriosis recurring, bearing in mind we don't actually know what causes it, so we don't quite know why it recurs?
Well, you hit the nail on the head in the last sentence where you said, so it is difficult, but I think first of all, you want to make sure that you have the surgery with the right surgeon, and what surgery has been performed and whether it's complete. So that's definitely one thing that needs to be ensured. And post-operatively, because we know that when we manage symptoms for endometriosis, we have to look at the holistic picture, a comprehensive management. And I think that's something that needs to be carried on post-operatively as well. So you look at your diet, you make sure that you don't eat too many pro-inflammatory foods, which can cause more inflammation. We know there is an association between the intake of alcohol, caffeine, for instance. Reduce that intake as much as possible if you can do it. Then coming on to making sure that you can use a medical treatment. And like I mentioned earlier, at the moment, we unfortunately do not have any non-hormonal method in terms of medications, which potentially can reduce the risk of recurrence. So we are coming down to those medications that are available. And so far we have some decent evidence that patients who do stay on a long-term progesterone containing or even combined oral contraception pill after surgery have a lower risk for recurrence requiring surgery. It's not that black and white, unfortunately. And I would definitely say, carry on with other things like making sure that your pelvic floor is relaxed enough, so that you don't really create a hypertoned muscle area there, and that can sometimes cause more pain, and that might mimic as if you might have endometriosis. Yeah, so I'm sorry, there aren't really like very solid answers that I can give you, but definitely I recommend all my patients when I counsel them for surgery that, unless you're trying actively for a baby, use some hormonal treatment.
And I think going off piece here, because it's not surgery, but you mentioned about a pelvic floor, and I think that in society we get like really pushed that we should have a really tight pelvic floor, but actually for endometriosis that can cause pain. And we have got some webinars on physio, etc. But again, I do know about people who've had surgery and still being in pain, but then done pelvic physio to relax their pelvic floor. So again, if you do speak to your healthcare practitioners if you are having ongoing pain, and do think about pelvic floor, but not as tight as I think that some people in the media think it should be on that one. So just whizzing on, because we go so quickly this time. I was going to, one person's asked a really specific question, but I think we do get asked this often, is why do you get shoulder pain after surgery? And Manou, do you want to give us an answer of that one? Not everyone will, but why do some people get shoulder pain? And Lexi's laughing and Elaine's laughing as well.
Oh, well, so shoulder pain is very common. I mean, one of the commonest reported symptoms after surgery. We have it less often in some patients, others have it more frequently. The reason why it happens is because when we have to go inside the abdomen, we have to put a gas. It's a CO2 gas to inflate the abdomen and the pelvic area so that we can create like a space to be able to see different organs without them being all, in a very narrow space together with each other. So we won't be able to, we want to be able to get certain structures outside the pelvis, so that we are mainly dealing with the pelvic side walls, with the uterus, the ovaries, fallopian tubes, and the rectum. But at the end of the procedure, we have to also make sure that we remove as much as possible of that gas. And now some of that gas gets trapped within the abdomen, in between the bowel segment. And as much as that we, try to get rid of it at the time when we, before we close the abdomen, sometimes some gas gets trapped, and some patients are more susceptible or more sensitive to have that kind of pain, and that is caused by our diaphragm. Diaphragm is a muscle, a breathing muscle, which dissociates or separates our chest wall from the abdominal cavity. And it typically has some connection with the nerves, which innervate the shoulder area. And that's why you get often, typically on the right side, more so pronounced pain. It's also something that shouldn't be really worrying you, because often the gas slowly starts to get resolved whilst you're walking around, you're mobilized. I always tell my patients to make sure that, change positions frequently, and that helps to get the gas absorbed by the body so that it's eliminated, and then you feel quite quickly better in about 24 hours, sometimes 48 hours, but mostly in 24 hours, it's kind of disappeared.
Brilliant. So it's not that so it's referred pain from your diaphragm having an impact. Now, Lexi, you were sort of smiling wryly when we talked about that. Is that something you've experienced?
Yeah, every time. I think I've always experienced it, and both of my sisters also have endometriosis. They've both had surgeries, and they've had the same as well. And we've all said in some way or another that is one of the worst parts of the early recovery, is that pain. It takes your breath away a little bit. You do have that feeling of not being able to catch a proper breath, and it hurts, but it does go away. And getting up and moving makes you don't feel like you want to get up and walk around, but actually getting up
sounds contradictory, right? Because you think, I'm in pain, why do I need to move?
stay still. Yeah, I want to stay where I am. But actually getting up and walking helps move it around a little bit, and like I said, helps reabsorb it. And that's what I found. It does help. And peppermint as well. A lot of people find that either peppermint, you can get peppermint water sometimes, some places will have that, or tea, polos, chewing gum, anything like that can just help make it feel a bit more comfortable.
Great, that's great. Thank you very much on that one. Now, one of the things that a lot of people are a little bit concerned about is they're waiting for surgery, and we know that there's long waiting lists, and we're obviously campaigning to get those reduced, and different hospitals are trying that. But Claudia, starting with you, we've had a couple of questions around, I've got surgery coming up, but it's going to be a while. what are there any diets or exercise that I can do, and also in terms of are there any other options for what I do in the meantime?
Yeah, so I think it's about having a really good conversation about options that are available. Obviously, hormonal treatments are a big one, which people often have bad experiences with over the years. We all know that, it's very easy for us to say, yes, you need to be on some kind of hormonal suppression, but actually if your mental health is massively affected by that, then that's a really big ask, and it's only you that can, weigh up what's, right for you and what's the best thing, but it's worth having a really good conversation about hormonal treatments, because people can be very afraid of them, understandably, but it may not have been explored fully. You might be able to have a discussion about other options. You may have had a really terrible experience with one treatment, but there might be something else that may be a bit less, it just may work very differently. So it's worth having that conversation, because obviously, hormonal treatment is the one thing that we, really do rely on, because if we can stop your periods, then we know that will often, not always, but in many cases, take away one big element of your pain experience, not all of it, but one big one. So that's probably the first thing. And then again, coming back to unpicking the different elements of your pain, it can be really overwhelming and all-consuming when you're just in pain constantly, and it can feel very difficult to unpick. But looking at the different things, and looking at things like physiotherapy. So I always say to my patients, the inflammatory active endometriosis with your period is one element, that you can be in a terrible pain because of your pelvic floor, which can be really, really tense, which can then impact on your bowel and your bladder function, which can then be really painful. So exercises to help with that through physiotherapy can be really good. Pain teams, if you can get to a pain specialist, that's great. They can do all sorts of different things. And again, it's about different types of painkillers rather than just, taking a load of ibuprofen or mefenamic acid or something. There are different things. You can get painkilling suppositories. You can get medications that you take every day that work on the pain pathways in a slightly different way. TENS machines, lignocaine patches, nerve block injections. These are all things that are available and are conversation. And it's easy for me to sit here because we have, lots of things available in our hospital. And I know that that's not the case for everyone. And I know that it can be a real battle to access stuff, and you can sometimes feel as though you haven't got those options, but it's worth going back and asking and saying, is there anything else? You may have been sent away with one thing and you've tried it and it's not worked, and you think, oh gosh, well, is that all I've got? But actually go back, don't feel as though, don't feel as though there's no other options. It's worth going and having those conversations. And I think, recognizing that, it's about what's available and unpicking things. Sorry, waffling again.
No, that's great. That's really helpful. Thank you. I'm just looking at the time, so I'm going to whiz on if that's okay. And one of the questions, one of the things that symptoms that people find quite difficult to manage on a day-to-day basis is often what people call endo bloat, so having bloating. And one of the questions is, will surgery reduce my endo bloat? Anyone wants to try that? Manu, do you want to kick off?
I will just share some experiences from my clinics, because of course I see my patients postoperatively. The bloating, once you have had surgery, it doesn't disappear immediately. So actually it might get worse in the first initial postoperative period. And I always warn my patients about it. However, once you are beyond the 6 weeks time, it should decrease significantly. And most women actually say, well, it's actually gone. So there is hope. If you have had like good surgery and the surgery is being effective, then the bloating can come down significantly.
And a good point you make, Manu, and I don't know if Elaine or Lexi got any comment on this, is I think sometimes we think, we think we're going to have surgery and I'm going to wake up completely better, but actually you've just had surgery and your body needs to recover, and sometimes it can take several weeks to do that. And I think we get people who are really worried because they've woken up on day 2, they've still got some pain. I don't know, Elaine or Lexi, if you've got any reflections on how long it took you to get to whatever normal might be at this point.
I had a lot of pain for, as I say, probably, I don't know. I mean, I was taking morphine just after the operation, but when I left the hospital, I was just on paracetamol and ibuprofen. And I thought actually that I was getting better, so I stopped. I think maybe a week or so afterwards, and the pain just kicked in, and that is when I realised the power of paracetamol and ibuprofen. So, I just kept on, but I was in a lot of pain for a long time. I mean, I remember the burning sensations. I couldn't even put my foot on the ground, and that lasted for quite a while. But I just took. I didn't take any prescribed medication when I came out of the hospital, which is what I'd always done. I used to take prescribed anti-inflammatories because after I was diagnosed, about a couple of years after, I was put on hormonal treatments and these GNR analogues, and they really, really didn't suit me. So instead of doing 6 months, I only did 3, and then I was put on some more other hormonal treatments. They didn't suit me, so I've literally had all of my journey just on one prescribed anti-inflammatory tablet, which I thankfully no longer take since the operation, and the bloating definitely gone, down a lot.
Brilliant, thank you. And Lexi, any thoughts?
I think it's for me, like I said, I've had very different recoveries depending on the surgery. Sometimes it can feel like it takes me a little bit longer to get back to normal. But one thing that I have done and I find quite effective is I'm the opposite. I'm really lucky in that a lot of the hormonal treatments really do help me. And not everyone does. As Elaine said, they didn't suit her, whereas I've taken the one that I've had is Zoladex. It's a monthly injection, and it worked really well for me. And I kind of use that to manage my pain so I can go longer between needing surgeries. And actually, what you're saying about the endo bloat, that's starting to come back is one of my early warning signs. I sometimes start getting that before I start getting the really intense pain. So if I can almost get ahead a little bit, I find that helpful. And it's again with pain management, I've had the suppository type painkillers, and I find them the best. Absolutely. That and paracetamol are my 2 favourite painkillers post-operative, and because they really help me. And it can take a bit of time, and it does. And for me, sometimes I still, I'm 6 months on from my surgery, I still get an occasional niggle, but you've got to remember that you've had surgery, and those places where you already experienced pain because of the endometriosis have now been further poked, prodded, cut, and you're going to have pain in the same places for a little while afterwards. So it's learning, it's finding that confidence that it isn't the same pain, and that can take a little bit of time to get your head around too.
Yeah, so if people have pain after surgery, do give yourselves time to recover from that one. Now we've not got much time left, but what I would like to do, we've got a few questions around fertility, and I know that fertility is surgery and fertility, this is, and the impact. And I know fertility is a difficult topic for some people, so just to flag that we are going to start talking a little bit around fertility in case anyone wanted to drop off. And so just moving on to fertility, one of the questions is around, and start with Manu if this is okay, around, so if someone is having surgery, they want to have children, and they've got cysts. So the question, so you can imagine that sort of thing. And people are asking sort of, is there a best time to have surgery or not? And then also, do you try and do fertility before or after surgery? And I'm giving you 3 questions at once, Manu, I do apologise. And also, if you're thinking of having egg preservation, would you do that before surgery or after surgery? So how does fertility and surgery work together?
They're quite, interlinked with each other. And I mean, these are very valid questions and very important ones to be addressed as well. Because, I mean, I'll try to be as concise as I can. So if you have endometriosis cysts on both ovaries, we're talking about endometriosis cysts and not the simple cysts, let's be clear. Then there are a couple of factors that will influence the decision of your surgeon to tell you whether you should have the cyst removed now or not. So that will depend upon your age, where you are in your fertility journey. So have you been trying for a very long time and not been successful, or have you never started a journey like that? And your age, because one of the biggest determinants in having a good fertility outcome is our female age. As we age, we unfortunately lose good eggs, and we lose not just the number but also the quality, and endometriosis doesn't do any good to that as well. So age aspect for sure. And then the second thing would be to look at your hormone levels. So some of the hormone levels we will review to see what your potential is to have good amount of eggs. Suppose if you would need an IVF stimulation, and that could be regardless of whether you need an IVF treatment or not. In case you are at an advanced stage, and we are talking about a age above 35 to make it simplified, but sometimes the ovarian reserve could be much lower at a younger age as well. So it's important for you to have that assessment in the clinic. Then sometimes we have a chat with the fertility team, and we then discuss, okay, this patient is seeking fertility, and that's something that we do in our MDT, for instance, because we have fertility specialists there, even if the patient is not looking for a fertility option at that moment in time. And they can then advise us, okay, given the ultrasound appearances or the imaging appearances, the hormone levels and the age of the patient, maybe it's best to not be too aggressive in terms of removing the cysts. And perhaps we should drain them first if they are very large. Sometimes we offer second stage surgery to make sure, we give some sort of medication afterwards to let the cysts shrink a little bit. You can imagine if you have a larger surface that you need to remove, the larger the size of the cyst would be, the larger it will have surrounding healthy ovarian tissue. So you're going to remove much of that. So sometimes that could be helpful. On other occasions, if you are in a younger category, you have good ovarian reserve, your cysts are not extremely large, then we can, have that conversation with you. Okay, well, we have a little bit of a risk of, damaging some of your healthy ovarian cortex, but you have, decent amount of potential to get pregnant, and then you can get the cyst removed at the same time. What was the other question, Emma?
Oh, I think you've covered most of it. I suppose around fertility preservation, if people are worried, so they
would you do that? Yes. So both for egg preservation or embryo preservation even as well. So suppose you are sent from the fertility team to us because you have been found to have endometriosis, and they can't access the ovarian tissue because of, endometriosis affecting the anatomy, then sometimes we are asked to intervene surgically and make the anatomy a little bit better so that they can go and, stimulate the ovaries, retrieve the eggs. Sometimes, on the other hand, you might have a scenario where you come to us and we see the endometriosis, but actually your ovaries are quite accessible for the fertility doctors. And they can then, if the cysts are not too large and there is a potential for ovaries to be stimulated enough, then sometimes it's best to drain the cyst, have fertility treatment, have eggs preserved, or make embryos out of them if you have a partner, and then freeze them. And then you can go on and have surgery, make the environment in the pelvis really nice, less toxic, less inflammatory, then have the embryo transferred back. So you increase your chances of success.
Yeah, thank you, Manou. I know that's a massive topic in its own right. You've just done very succinctly.
It's very important, and everybody's so worried, because I see all my patients, at least 70% of them are super worried about their fertility aspect, and I don't think we cover that enough. Yeah, and I think we talk about endometriosis impacting on fertility,
But it is worth bearing in mind that it's believed that up to 70% of women with endometriosis will be able to conceive naturally. So don't assume that you're going to have problems. Should you be having problems, the other thing, there's a nice guidelines, the National Institute of Clinical Health Excellence, around fertility, which states that if you have a recognised condition that impacts on fertility, you should be able to go straight to getting fertility support. So if you are concerned about fertility, do speak to your healthcare professionals, and if necessary, do get referred in should you wish to find out more about that, so that you can have informed conversations. Now, I am really sorry, but we are 3 minutes over. I just thought it was worth answering those. So we will stop now. We've still got loads of questions, so we might need to do another webinar or some follow up for this one. But could I just say a really big thank you to Manou, Claudia, Lexi, Elaine, and behind the scenes Ushma. Big thank you for your help tonight, but also your help. We've been developing resources on surgery. There's a video that's out at the moment on our website. We've got a whole host of other things. We're just finalising resources out as well. And if you do have outstanding questions and you think that having looked at all that, there's still questions that we're missing, please do let us know, and we will provide more resources to try and give you the information that we need. And certainly Claudia, although she dreads doing it, we have been around and talking about, filming at the local hospital, just so people can see different aspects of what goes on. So if there's something you'd specifically like, do let us know. And a big thank you to Elaine and Lexi for taking the time to share their experiences, which I'm sure will be very, very helpful to everyone else. So thank you everyone for watching. As I say, do let us know if there's anything else, and a big thank you to all the speakers, much appreciated. So